Neha ma'am, please start. Kindly unmute yourself. Neha ma'am, kindly unmute yourself.
Okay.
Thank you.
Okay. A very good evening to all the respected dignitaries, seniors and colleagues. I, Dr. Neha Singh, editor of Raigad IP and secretary AHA Raigad, on behalf of Maha IP and IP Raigad, I welcome you all on the first day of March, the day for our journal reading. I welcome Maha IP President Dr. Sanjay Pakmore sir, Secretary General Dr. Amol Pawar sir, State Convener Dr. Sanjay Deshmukh sir, Raigad IP President Dr. Vikas More sir, Secretary Dr. Ajay Kohli, respected Dr. Neeman Mohanty sir, and all the respected executive board members from Maha IP, Raigad IP, as well as other branches. I also feel privileged to welcome our esteemed experts of today, Dr. Aarti Kinikar ma'am and Dr. Abhishek Madura sir, as well as our presenters of today, Dr. Anil Akhare and Dr. Rohit Malik, reciting the famous lines, knowledge will bring you the opportunity to make a difference. I invite Maha IP President Dr. Sanjay Pakmore sir to please give his blessings. Over to you, sir.
Thank you, Neha. Good evening. Good evening, all respected Dr. Aarti ma'am and Abhishek, a friend of us, and Niman Mohanty sir, and all the office bearers of the Maha IP and the Maha IPians who are attending today's journal journey. This joint venture of Maha IP and the Raigad branch is a very good initiative which has continued since last 3 years. And every month starts with this journal journey program. And really it is so enriching, enlightening, because means lot of means we could see the lot of means the experts and the presenters are presenting, and the experts by their comments we come to we know lot more things, and it is a so that this is continued since all the last three presidents, because it is such an activity which gives I encourage or gives a push for all over the month for the other scientific activities. So all the best to all the presenters, and once again thanking Madam Aarti Kinikar ma'am, and as well as the Abhishek and today's presenter. All the best, and over to you, Neha.
Thank you so much, President sir, for your valuable input. Now I invite Dr. Amol Pawar sir to say a few words. Over to you, sir.
Thank you, Neha. I welcome all the delegates, both the presenters and both the experts, and Raigad IIP team and all the office bearers of various Maharashtra IIP district and city branches. This is very nice initiative, and as we all know, Dr. Neha Singh and Dr. Chitra Kulkarni ma'am, under the guidance of Dr. Jay Bhandarkar sir and Dr. Hemant Gangulia, and whole Raigad IIP team, Vikas More sir, then Sagar Koli sir, Sagar Khedu sir, then Kohli sir, Ajay Kohli sir, and entire team Raigad IIP. They have started this journey since last 3.5 to 4 years, and it has been continued as Sanjay Pakmode sir has told that previous all three presidents have continued it, and now also this year it will continue, and I think it will continue for many more years to come. So I wish all the best to both the presenters, and whole Raigad IIP team. Thank you. Over to you, Neha.
Thank you, Amol sir. Now I request Dr. Sanjay Deshmukh sir to say a few words, sir.
Good evening. Welcome all respected office bearers of Maha IIP, human wing members, team IIP Raigad, Dr. Neha, Dr. Chitra ma'am, Dr. Vikas, Dr. Kohli. The general journey is absolute fun, because I was just going through the presenters today. We have two dynamic presenters, Dr. Anil Akhare, or from Vidarbha Yavatma, and Dr. Rohit Mae. And the topic, non-invasive pediatric respiratory monitoring using video depth camera. This is much interesting because I never heard this. So hats off to the scientific team for making this general journey and taking innovative topics. So we thanks the expert Dr. Uh, uh, Mohanty sir, Dr. Arti Kinikar ma'am, and our own Abhishek Madura. So let's welcome them all and begin the session. Thank you.
Thank you, Sanjay sir. So now I invite Raigad IP President, Dr. Vikas More sir, to say a few words. Over to you, sir.
Thank you, Neha. Uh, uh, First, I want to thank our respected Dr. Sanjay Fakmore sir, our respected MIP President, and our dear friend Dr. Amol Pawar, Dr. Sanjay Deshmukh sir, who is always very helpful for Raigad IP. And they are supporting IP Raigad as much as possible. And I'm very proud that they continued their journey even during their tenure. We got a very esteemed experts today, Dr. Arti Kinikar Madam, Dr. Abhishek Madhura sir, who is from Nagpur. Kinikar Madam is from Pune. So again, we got a very good experts. So, and speakers, Dr. Anil Akharin, Dr. Rohit Male. So we are very excited to have two interesting topics. First, though common but very important, which is updates on TB treatment, and second is the video use for the respiratory monitoring. So we know that our academic background equip us with a technical knowledge. It skills which need in our profession. So the routine practice. So though the general journey looks like a very dry academic subject, but it will definitely help all pediatricians throughout the state in their routine pediatric practice, because our respected Niman Monti sir is purposefully selecting very practical topics every month, which will help not only the students but also the practicing pediatricians. Again, I thank Mohanty sir and Dr. Chitra madam for consistent effort that they are putting in for empowering all students and pediatricians to increase their. Also, our team, Neha, Vishal, everyone who are helping us to just go on this journey. Thank you so much. Over to you, Neha.
Thank you, Vikas sir. So now I invite Dr. Purva Jain, who will be with me moderating the session. She is Assistant Professor at MGM Medical College, Kamote. To please introduce our experts and presenters of today. Dr. Purva.
Yes, ma'am. Good evening, ma'am. Thank you so much. Can you please share the slide, ma'am?
Yeah.
I'm very privileged to introduce our experts and the speakers both. So the first expert is Dr. Aarti Kinikar, ma'am. She is a professor and head and vice dean in a BJ Medical College and Sassoon at General Hospital, Pune. She has a teaching experience of 39 years. She is an honorable secretary, HMBI from 2021 to 2023, Fogart Scholar in a Johns Hopkins University, USA, OTDS Scholar in Royal College of Physicians, UK 1995, Fellow IAP in 2023, Dr. PM Odani Oration in 2023, Best Medical, she has got a Best Medical Award, Teacher Award in MUHS Nasik, Indian patent for a low-cost ventilatory circuit. She has started DM neonatological course of MUHS at BJ Medical College, Pune 2023. She is also a national trainer for QI, NRC, RBSK, IVCF, AFI, TB, HIV, COVID-19, IPBLS, FBNSC. She has a research 170 PubMed Index research publication citations. She's a principal investigator in NIH USA, ICMR, DBT funding MRC UK, MRC South Africa, Australia, DAPH HOD Southeast Asia. She has got a research awards in NIH GOM, BMG, Aviskar Governor. She is the Center of Excellence Nodal Officer, Clinical Genetics, HIV, TB, COVID-19, FABNC, and SRC. She's also the state task force member in H1N1, COVID-19, child death audit, GBS, HMP, etc. She's the chairperson of state AEFI committee. She's also chairperson at TAPH HOD Southeast Asia Steering Committee 2021, 2022, 2025, 2026. She's also chairperson OR State Committee NTP 2023, 2024. The second expert is Dr. Abhishek Madura, sir. He's an associate professor, pediatric in charge, allergy and pulmonology clinic in AIIMS Nagpur. He's a fellow. He's a fellow pediatric respiratory medicine RCPH London, UK. Diplomate pediatric respiratory medicine from Switzerland. DPA Center of Excellence, New Delhi. DPSM Shishurka Children Hospital, Bangalore. He has a clinical experience of 19 years and a teaching experience of 14 years, UG teaching 10 years, PG teaching. He has a 13 publication, 2 book chapters, and area of interest is pediatric pulmonology, allergy, asthma, pediatric sleep medicine, pediatric TB. He is a member of an affiliation of ERS, ICS, IAP, NRC, Peach Sleep Association, EACIN. Also, he's an IAP allergy chapter. Two experts, the first one, two speakers. The first one, Dr. Anil Akare. He has done MBBS from Government Medical College, Nagpur, DCH from MGM Medical College, fellowship in neonatology from BJ Wadia Hospital, Mumbai. Presently, he's a registrar at Sri Vasantrao Naik Government Medical College, Yavatmal. Our second. Today, he's going to speak on the updates on the treatment of drug-susceptible and drug-resistant tuberculosis. Now, the second speaker is Dr. Rohit Male. He is an MBBS MI MSL Latur. He has done MD Pediatrics from Latur. He's an assistant professor in Department of Pediatric Latur. He has a 3 publication. He's today going to speak on visual measurements of breathing parameters in children with a particular focus on face angle, a pilot study. So now I request for the my first speaker to start on the topic of updates of the TB guidelines. Thank you so much.
Hello, good evening, everyone. I am Dr. Anil Akare. First of all, I am very thankful to Dr. Sanjeev Joshi sir and Dr. Chitra Kulkarni madam to give me opportunity to speak on this recent update on the treatment of drug susceptible and drug resistant tuberculosis. I also thankful Dr. Kinikar ma'am for her wonderful guidance. I also thankful Dr. Sanjay Papmode sir, Dr. Amol Pawar sir, and Dr. Sanjay Deshmukh sir for always constantly encouraging me throughout my journey. Today's topic is update on the treatment of drug susceptible and the drug resistant tuberculosis. The publication, this article is published in American Journal of the Respiratory Critical Care Medicine. It is published in the volume 211 from page 15 to 33. The journal is published by the American Thoracic Society with the DOI mentioned in this current slide. These are the official ATS, CDC, ERS and ERS clinical practical guideline. These are clinical practice guideline which was approved by the American Thoracic Society, Infectious Disease Society of America, Disease Center for the Disease Control and the Prevention, and the European Respiratory Society. The impact factor of journal is the 3/6. The methodology used in this review journal is panel composition, conflict of the interest management. The main guideline development methodology includes the grade development. That is the grading of the recommendations, assessment, development and evaluation, adaptation as needed, de novo development of recommendation processes, includes evidence to decision framework. The main methodology used in this review article is the PICO, that is population intervention comparison outcome question for the development, and then they use the modified Delphi process for the prioritization of the critical outcome. These are the two strong and the conditional recommendation used in the methodology. These are used both for the patient, clinicians, and the policymakers. Policymakers can use this for the better policy making. Being in India, we all know that the tuberculosis is the main epidemic problem and the main infectious disease. Though we have the separate recent RNTCP guidelines and the different IAP guidelines to manage the drug sensitive and the drug resistant tuberculosis, we have to incorporate the newer knowledge from the Western society and the European countries so that we can make our population the tuberculosis free. The literature search, they are usually main the Medline, M-based Cochrane Central Register. Then they use the independent review done by the ATS document editor. The result of this review article is that new drug susceptible TB recommendation include use of the novel 4 months regime for the people with pulmonary TB and the shorter 4-month regimen for the children with the non-severe TB. The drug resistant TB recommendation include use of the novel drugs like bedaquiline, protenamide, and linezolid. Sometimes they are used with or without moxifloxacin. The main discussion of this review article is that adults and the adolescent with the drug sensitive TB may offer the 4-month rifampicin moxicillin based regime, whereas the drug resistant new TB includes the 6-month regime, and which are the more effective and safer than the standard of care regimes of the WHO. The evidence supports the higher treatment success rate with the MDR and the rifampicin resistant TB, which mainly include the bedaquiline, protenamide, linezolid with or without moxifloxacin. Study also recommended the BPLM as a first line for the MDR and the rifampicin resistant tuberculosis, which can be used with the fluoroquinolone resistance or the intolerance. These are the studies 31A53459, which are mostly in the PICO question number 1, which used to compare between the 4-month regime, that is HPZM to HPM, with the 6-month regime of the 4HRJD. The another trial, that is the SHINE trial, which is the open label parallel group non-inferiority randomized controlled trial, which used to compare the intervention of the 4-month regime, that is isoniazid, rifampicin, and the pyrazinamide with or without ethambutol, to with the 6-month regime of the isoniazid, rifampicin, pyrazinamide with or without ethambutol. This trial is used in the PICO question number 2. The inference of this review article is all oral shorter treatment regimes for TB are now recommended for the eligible individuals. The cost effectiveness, impact on the health quality, acceptability, and feasibility are the hallmark of these new drug regimes. These are the different PICO questions which are used for this review article as a methodology. The PICO number 1 includes the treatment of the isoniazid susceptible, rifampicin susceptible TB in the mainly the adults. They compare the isoniazid, rifampicin, pyrazinamide, moxifloxacin regime, and they recommended this 4 months regime for the isoniazid susceptible and the rifampicin susceptible tuberculosis in adult. Then for the treatment of the non-severe presumed isoniazid susceptible and the rifampicin susceptible TB in mostly in the children, which are very helpful for the IAP and our RNTCP guideline. They recommended the isoniazid, rifampicin, pyrazinamide, ethambutol regime, which also we are used in the RNTCP guidelines also. Then for the rifampicin resistant and the fluoroquinolone resistant tuberculosis, they recommended the novel BPL regime, that is bedaquiline, protenamide, and the linezolid. The number 4 PICO question, which used for the treatment of the rifampicin resistant fluoroquinolone susceptible tuberculosis, they recommended the novel 3 drugs, including the moxifloxacin and the newer drugs. The positive outcome of this study is they are of the shorter duration. The oral regimes are most of the time used. The reduced number of medication and the reduced pill burden and the less adverse risks are helpful for the both patients and the clinicians. The next cost of implementing new regimes improve with the fewer patient visits and potentially offsetting the higher cost of medication and the drug sensitivity test. These are the main slide of this review article, which includes all the 4 conditions where the child between the 3 months to 16 years old, we can interpret through the chest radiograph that which regimes we can be used in our setup also. The clinically diagnosed or the confirmed TB regardless of the symptom and the respiratory smear negative and the no drug resistance suspected if there, then we will first do the chest radiograph. If chest radiograph is normal, the peripheral lymph nodes are involved, then we can use the 4 months regime of the HR twice HRZD plus twice HR. Then second condition where the chest X-ray suggestive involvement of the less than one lobe and the non-cavitary lesion, where there is the intrathoracic adenopathy or the simple pleural effusion is there, where we can use the 4 months regime of the twice HRZD plus twice HR. The third condition is a chest X-ray with the cavitary lesion with involvement of the more lobe and complex pleural effusion, where you can use the standardized 6 month regime, that is twice HRZD plus 4 HR. If there is a suspicion of the extrapulmonary TB and there is no involvement of the peripheral lymph node, such as meningitis, biliary tuberculosis, or the skeletal TB, where we can use the rifampicin moxifloxacin 4 month regime. The shortcoming of this study are the main shortcoming of this study is methodological, that is using of the development. But in this case, the level of certainty of evidence is very low. The study also did not review the data available to the WHO. The main PICO question focused on the WHO recommendation are updated earlier to the prior joint panel guidance. Several new regimes were out of scope of these PICO questions, and the main shortcoming of this study is that PICO questions number 3 and 4, which are focused on the 15 months or the greater comparator regime, not include in the WHO SOC regimes. The future recommendation or the future prospect of this review article and the newer study is that participants excluded from this study, like children with severe TB or the drug resistant tuberculosis, pregnant individuals can be excluded from this trial, and the new regimes of the emergence of drug resistance can be informed in the further guidelines. The joint panel guidelines update 2016 and the 2019 TB treatment mainly focus on the DS and the DRTB. Patients who are not fit in this category, the joint panel prior guideline can be consulted in this way. The study also continued to recommend the drug sensitivity to guide therapy, whereas the DOT and the integrated cash management will remain the standard of care. Thank you so much. Now I will ask to proceed to Dr. Kinikar ma'am for her expert reviews.
Thank you, Dr. Anil. If you can just stop sharing, please. Dr. Anil,
Yes, ma'am.
before we start, I would like to thank the Maha IIP president, the president of the Raigad IIP, and of course, Dr. Minaz, who brought me into all this with Dr. Neha conducting the show today. So it's a great opportunity to interact with you. What I agree with Dr. Anil is that he has done a comprehensive job of giving you an overview of what this article is. Now, you have to first understand that this is not a research article. It is a consensus guideline article. So when you present a consensus guideline article into a journal club, it has a little different format in which you need to understand. If you look at that article, this article is meant for places where there is low TB incidence and a very high laboratory setup. So basically, these guidelines were an update of the European and the American guidelines of 2016 and 19, because there were research articles which were published after 2019, and WHO had accepted those research trials and they had changed their guidelines. So that came in 2022. And then what happened is they felt that these are good articles. All the 4 articles are from published articles in New England Journal of Medicine around 21-22. And then they looked at all this. So this particular consensus guidelines are updated guidelines of the old WHO. So when you present such an articles which are there, you should understand basically how did they go about coming to the consensus guidelines that could be applicable to the developed countries where there is low incidence. What we have to see here is whether how much we can apply from here with its limitations, etc. Now, one of the research articles, which is the SHINE study, I was the principal investigator for it. And that is the one only center in India, that is BJ Medical College. So it's a teamwork. And the other sites were from South Africa. So that study is included in this, which WHO modified the guidelines for non-severe TB from 6 months to 4 months. So 4 months is not inferior, it is almost equal. So WHO changed the guidelines. And this is the only trial with 1,200 children randomized to the groups. So the largest clinical trial in pediatrics. So that is one of them. When you look at the remaining 3, they are also done in countries other than India. They are in Russia, they are in Africa, they are in Kazakhstan, etc. So the rest of the 3 are not. And out of which today, which India has accepted, is the BPAL regimen. That is, which Dr. Anil told us that it will shorten the duration of treatment in the drug-resistant TB. Today, you know that it is 15 months, 18 months, 24 months, it goes on. And then you have different types. So they have looked at what are the plus points in that randomized control trial, what are the deficiencies in it, and all that is beautifully depicted in this article. So when you read it, you feel that these are very good regimes. But then you look at the way they have analyzed. What is this Delphi method? Delphi method is when a group of experts come together, almost 25 of them have come together, and all these 4 published trials have been discussed in multiple rounds. Then they have gone to the experts, and then they used that method called development and the grades. So that adopt means you either adopt the guidelines as it is, you don't make any change. So you just agree, yes, this is applicable, suitable for my country, and I will use it. The adaptation means you will have to modify it. That the trial which was done in India may not be applicable in the US or the Europe. So they will modify it. And that they have beautifully mentioned in the methodology by asking adapted questions when they develop the PICO question. And the third part is de novo, means you just develop a new guideline itself because you cannot adopt it, adapt it. So this is how that development thing stands for. As far as grades is concerned, now IAP is coming out, Dr. Amol is here, Dr. Pakbode sir is here. IAP is coming out with multiple guidelines. If you see our old guidelines, we never use this grades classification or development. By expert opinions and looking at the literature, we came to the guidelines. But now it is mandatory that you use it. And the way they have analyzed all our guidelines are slowly at central IAP, making it compulsory that you need to understand this research part called grading, whether I can accept it or I should not, or with reservations. So the BPAL, which is there, which India has adopted as it is, but when you see the literature, the shortcoming is one of the side effects when they did the animal studies on male rats. One of the side effects of pretonomide was testicular atrophy and infertility. When they did the same study in the macaws, they did not find that. So when we adopt it over here, we have to make sure that if we have adopted, it is our ethical duty to monitor these patients, because it is now used over 14 years of age. You can use the 6 months BPAL. And BPAL-M is another one where you can use it if there is no resistance to fluoroquinolones. So when you look at, this is just before I just stop and I go for the questions if there are, when you present a consensus guideline as a journal club, the first part Dr. Anil did beautifully, that is the introduction. That why do we really need shorter treatment guidelines? Because they are easy and adherence is very good, and a normal patient can be put back into a community, becomes non-infected with shorter regimes than longer. The methodology which they used, the American people used to come to a consensus is nothing but the Delphi method and this development beautifully sort of depicted. They did a review of literature. They have put their recommendation, which was the second last slide in Dr. Anil's presentation, what they want America to follow. And if you read it, the last line is go back to the dots. Somebody has to make sure that the medicines go inside the patient's mouth and is taken. So adherence issues need to be done, and they want the drug sensitivity. Now, in a country like us, it is very difficult to get the drug sensitivity testing done the way they have recommended. They were done under clinical trial condition, but in a program, it is very difficult to get the ideal situation. So programmatic thing is different from the other. So we have done a study of 3 HP in programmatic that is also accepted by WHO. They have changed the guidelines. So we have a total of about 4 research things done in BJ Medical College, which have changed the WHO guidelines. But that doesn't mean that we can implement it as it is, because Government of India has to accept it. And that is called as adaptation to our country, because the studies may be done on small numbers. The limitations you have very rightly highlighted, they have compared one study, which was 9 months, to a 15-month study. Now, in research, this is non-comparable group. So the interpretations you will get from it may not be applicable. And the implementation in India for the shorter treatment, the one which we were part of it, SHINE study, is still not approved by the Central TB Division. So we are not, the only problem they say is how can a person sitting in a remote area diagnose non-severe TB? But the non-severe TB is defined, and I think everybody can read an X-ray today, because the guidelines, our own NTP guidelines also start with a chest X-ray today. So those are also highlighted over there. And also the last slide, what were the limitations in this study? If Maha IIP, Raigad IIP want to take up any of these research projects, I am there to help you. You can conduct the trial, because we need Indian data. Without Indian data, we may not be able to implement the various research which is going abroad or in other countries or even in our own country. So a very well presented, Dr. Anil. You put everything in those 10 slides over there, and we can take it up further if anybody is interested or they have any specific questions before I stop here. Thank you.
Thank you, Aarti ma'am, for such an elaborative way of explaining the topic. And thank you, Dr. Anil, for the presentation. Now I request our second presenter, Dr. Rohit, to please share the PPT. Over to you. Attendees, please share your questions in the chat box. We will take all the questions at the end of both the presentations.
Yes. Is my PPT visible?
Yes.
Is it on full screen and am I audible clearly?
Yes, everything is perfect. You can start.
Okay. Good evening, everyone. Myself, Dr. Rohit Male. I'm an assistant professor from VDGMC Latur Pediatric Department. First of all, I would like to thank Maha IIP and IIP Raigad for giving me this opportunity. Heading towards the topic of today, that is non-invasive pediatric respiratory monitoring using video depth camera. Okay, It's a novel approach for measuring the breathing parameters in children. Till now, what we use is the spirometry. This is something which is going to replace a spirometry. Basically, spirometry is a quite cumbersome process so far pediatric age group is concerned, due to which this uh, technique has been evolved now. So So the impact factor of this article is 1.2 for the period of 5 years from 2022. So limitations of current pediatric respiratory monitoring method is, first of all, it's an invasive method. Okay, then it is uncomfortable and stressful for children. It's a cumbersome method and difficult to use and interpret, especially in pediatric age group. So there is a need of some non-invasive and easy to use technique, which is this, which we are going to see today. The aims and objectives of this presentation or this method is to introduce a non-invasive and remote procedure for measuring the breathing parameters in children, validate the accuracy of the proposed method, and to measure the respiratory rate, volumetric changes, and the phase angle between the chest and the abdomen expansion. The things which are used in this technique is a camera, and the current technology is based on the Intel camera, which is RealSense D435 depth camera, the lung simulator, and respiratory rate, phase angle, and tidal volume were estimated on a video recording of 2 custom designed dolls, okay, which are programmable with a simulator lung inside it. One doll is baby sized and the another one is of adult size. So here you can see here the one mannequin which is of adult size and the other one is of a baby size. Okay, and this is the thing which we are calling it as a camera. So all the recordings followed a rigid filming protocol, ensuring a doll was lying face up, as you can see here, and the camera is positioned 40 to 50 centimeters above and facing the doll, capturing the upper part of the body in the front view. And the 3 colored stickers were placed on the doll's body to detect the future points. Okay, substituting the nipples and the navel area. So the calculation of the respiratory rate, phase angle, and tidal volume were performed on sequential sliding window of 15 seconds. Recording of 30 to 60 seconds video using a video depth camera has been done and detected future points at the nipples and the navel using the computer vision algorithm. Analyzing signal frequency to estimate the respiratory parameters. Okay, so this is the figure. Okay, first each video frame was processed separately, keeping the timestamp, and the stickers were detected. Centroids are extracted and the distance between them has been calculated. The distance were then normalized and plotted as a function of the time. So this is the interpretation of that camera. Here you can see this is the stickers placed on the baby's body, and after interpretation the camera is going to stick such kind of picture. So now the estimation of respiratory rate following the distance between the 2 future points and a function of the time allows us to track the breathing cycle. The respiratory rate, commonly measured by the breaths per minute, can be estimated by continuing the number of cycles or peaks in the signal or the number of zeros crossing when the signal amplitude is normalized in the range. This is a chart where we have validated whether this technology is working properly or not. there are few patients like the second, this is the 3 years old, means 3 years and 11 months old patient is a male. This is a line where it is showing a manual breaths per minute. Manually, when we have calculated, it came up to 24, and our system has calculated it as in 24.3. So you can see that the system is working extremely beautiful, means the interpretation is almost same. The next patient, 9 months here, I mean 9 years and 3 months old female. Here you can see manually when we have calculated the respiratory rate, it came up to 22, and our system has been calculated it as 20.6, so we can consider it as in 21. The same has been depicted in this table. This is a graphical diagram where the respiratory rate as well as the tidal volume on the dolls has been shown. Okay, so here you can see the upper one is the respiratory rate and the lower one is the tidal volume. The one which you can see in a blue is manual, and the one which you can see in a red is done by our machine. Okay, so you can see that both are almost equal. So by this slide we can validate that this technology is really working good. Okay, now the part is estimation of phase angle. Now the phase angle is the measurement of a temporal movement of one body compartment in relation to the another during each breath, and in this case was determined by the offset between the chest and the abdominal compartment. Two virtual belts. These are the virtual belts. Okay, these two virtual belts were defined approximately horizontal strips of the respiratory inductance plethysmography, which we use conventionally. Belts were covering the rib and abdomen, enabling the. So here you can see these belts. These are the virtual belts through which the signals has been received. Okay, by which we are going to calculate out the phase angle. Now estimation of the tidal volume. Okay, tidal volume, the volume of tidal breath is approximated by Riemann sum over a predetermined region of the interest. Each camera pixel has its own x, y, and z coordinates, thus enabling the computation of Riemann sum on the rectangular grid. We assume that the grid coordinates on the x and y plane remains constant during video filming, and thus the change in the depth, which is derived by the z coordinate, accumulates to the volume. So in this way we are going to calculate the tidal volume. Now while using spirometry, we have issues in pediatric age group. It is very cumbersome process. Almost it is impossible to calculate these parameters, but by this video depth camera we can use this technology in pediatric age group. It is invasive, no patient coordination is required at all. Patient is lying comfortably on bed and the camera is doing its work. The results which are obtained, they are easy and accurate. On other hand, while using spirometry, it's first of all it's an invasive process and it requires a high patient cooperation, which is quite impossible in the pediatric age group. So that is why this video depth camera is going to be a revolutionary change in respiratory rate or the respiratory parameters monitoring. So the conclusion is propose a non-invasive remote procedure for measuring breathing parameters in children, validate the accuracy of the proposed method, and offering a promising solutions for pediatric respiratory monitoring. Future work is to investigate the use of the proposed method in a clinical settings and explore the application of the proposed method for monitoring the respiratory disease in children. Thank you so much.
Dr. Rohit, you can stop your presentation. And I would request
Yeah.
Dr. Abhi to please give your expertise or comments. Sir, please unmute yourself. Okay, Pallavi ma'am.
Hello. Yes, there was some technical difficulty while unmuting. So this was a very tough topic, and I must congratulate Dr. Rohit to present this case, this study with a calm and composed posture. The thing is, first of all, we should understand why this test or this technology was thought of thought of designing it. The reason is most of the times you have seen that the respiratory rate is not being monitored in the hospital settings, leave alone in the private clinics. So the reason behind that, the studies have shown that the reason is it takes around 60 seconds every time to accurately calculate the respiratory rate. And the nursing staff, usually they are already overburdened and overburdened with their jobs. So they usually tend to omit this parameter because it is not reflecting in the multi-para monitor. So one of the reason is that. The second, the reason which the London group had shown was that the doctors, they were using the spot technique versus the formal technique, where they have shown that the spot technique where they they are eyeballing the patient and they're saying, okay, the respiratory rate seems to be high. So they have said that most of the doctors, they were getting it wrong and they failed to accurately measure the respiratory rate. So these are the challenges for which this technology was developed or is being developed. Now the thing is, what they are using is called a photoplethysmography, where a static camera is used, where you are taking the picture or the video for 30 seconds or 60 seconds, and then the signal is being processed, and then it is being generated into a data where it is having a clinical relevance. Now with this study, yes, it has a good effect. It has got a place in the research, but as of now, this technology cannot be used as it is in the clinical setting. The reasons are, first, this is being done in a doll, and this results cannot be extrapolated in a real world scenario. One. Second, they have used a fixed simulator where they have used a fixed rate, say 20, 30, 40, 50, and so on. In clinical settings, especially in pediatric patients, you don't get a fixed rate of 20, 30, or 40. The child will breathe accordingly based on the need, and there is variability. Interbreath variability is also there. So that has not been accounted in this study. Secondly, if you see, they are using the rib bands, the virtual rib bands or the respiratory impedance plethysmography bands, which they are saying. So in that, they have seen a concurrence with the movement, but this movement actually requires proper well-lit ambient light. So in scenarios where the ambient light is less, the camera, how does it perform? That will be a limitation of this study. So we don't know about that. So third, the limitation of this study is the video has to be used for 60 seconds. So if a person is standing there and holding a camera for 60 seconds, he might as well use his own seconds hand and see and measure the respiratory rate by himself. So that this technology in the current form is not actually helping in reducing the intervention, the human resource which is needed to see the respiratory rate. What Dr. Rohit mentioned was that for tidal volume, it can replace spirometry. Well, in the future, it might, but for replacing spirometry, it's a big task, because spirometry is actually not only going to give you a dynamic assessment, as it also gives you a static assessment. So for dynamic flow, you use spirometry, and for static volumes, we use body plethysmography. So as of now, this technology, what exactly is going to help is in detecting the respiratory rate and also the paradoxical breathing. So they have in the authors have actually mentioned that the phase angle is different. So if you see that table which Dr. Rohit has shown, in that they have used minus 130, minus 120 degrees phase angle shift. So that minus is basically the out of phase which is happening. So when you have a negative sign, it is actually out of phase. That means there is paradoxical breathing happening. Okay. So in that sense, it is very good. What we can, in the future, what we should actually use is a LIDAR technology, where you don't have to open the chest or bare chest. For this video camera technology, you use a the child has to be bare chested. So privacy is a issue. So for a adolescent girl or a boy, or in adults, this might be very uncomfortable. Some camera is looking at your chest. So this technology adoption by the patient as well as the caregivers would be a difficult thing to do. Whereas certain other conditions, technologies which are being explored is the LIDAR technology, where they use the laser, and in that we use the what you call the lasers to extrapolate the shape of the chest, and then we decide the respiratory rate as well as the respiratory volume. We are trying to start that project very soon. But then as of now, with this study or the journal which we are presenting here, it gives us an insight that we can use this technology in a right way, in a proper form, in our Indian setup. Especially if you see, it can be very helpful if we have a handheld device which can be used in, say, at the hands of ASHA worker. So she just has to point it like a gun in front of the chest of the patient, and the respiratory recording would be there. So this would definitely help in the case management of respiratory illnesses, especially pneumonias and asthmas. So the screening part can be taken care of at the community level. But there is a long way to go for this technology to be developed in that fashion. But I really appreciate and thank Dr. Rohit to come up with this article, and he presented very well. And I also would like to take this opportunity to thank Dr. Pakmode sir and Dr. More sir and his entire team for inviting me and having me in this forum. Regarding one of the participants has asked whether there is a clinical how can we use this in clinical practice. So as I said, as of now, this technology is not that evolved to be used in a practical way in a clinical setting. But yes, people are trying to come up with these new technology, so that we can, as physicians, we can use it in the OPD practice. Like you have that Fitbit, you have this Google Fit, you can actually monitor your respiratory rate in that also. But it is not meant for that. The technology is not that validated for this kind of use. So as of now, the jury is still out. We don't know whether this technology can be adopted as it is and in the present form. Thank you.
Thank you, Abhishek sir, for your expertise, comment, and practical tips. So now I call upon Purva. Are you there? Pallavi ma'am, do we have questions on YouTube?
No, ma'am, there are no questions.
Okay. Rightly, sir.
Neha ma'am, there are no questions on the chat box.
Okay. Can we use in bronchiolitis? Dr. Lalit Mishram sir has written one question, and then you have already answered, Dr. Abhishek sir. So Purva, can we go for the vote of thanks?
Yes.
Before that, I would request Neeman Mohanty sir.
No, both these topics have been covered well by our experts. No further comment. Actually, is very rightly pointed out. But this device is under development only, and with the AI, we hope the faster we develop it is good. And if we can start it in our own setup somewhere and develop it, validate it in a real time with the patients, it will be nice. Just to select these topics are to just develop an insight amongst us. What is in the offing, what is in the pipeline, maybe in a year or two, such devices are likely to come with the aid of AI. Thank you.
Thank you, sir. Dr. Purva, yes, you can continue.
Yeah. Hello.
Yeah.
I'm audible?
Yeah.
Am I audible? Yeah. Thank you. It was such a knowledgeable journal journey of today. It's really a good opportunity to make a difference in the knowledge. Both the topics has been covered very in details. I'm very thankful to both the expert, Dr. Aarti Kanikar ma'am and Dr. Abhishek Madhura sir, both the speakers, Dr. Anil Akhare and Dr. Rohit Male sir, for their efforts for putting in both the new topics. And I also like to thank to Dr. Sanjay Pakmore sir, President MA IIP, Dr. Amol Pawar sir, Secretary General MA IIP, Dr. Vikas More sir, President IIP Raigarh, Dr. Ajay Kohli sir, Secretary IIP Raigarh. Special thanks to Dr. Naveen Mohanty sir, who is my MGM, who is always with me and always there with me with MGM. To Dr. Neha ma'am, who always supports me in the journal journey, Dr. Chitra Kulkarni ma'am, who's always there with me. And today's topics has been covered very nicely. And also to Pallavi ma'am for all the back end, for all the back slides and for all the things has been done. And it was such a nice journal journey of today's.
Mohanty sir, would you like to tell the topics for next session?
Dr. Chitra, I have sent these topics. Do you have that with you? I'll just find out.
Yes, sir. The topics for next session, that is 1st of April, is etiology, characteristics and outcome of neonatal liver failure, lessons learned over the last 3 decades. And the second topic is mental health screening and measurement in children and adolescents.
Yeah, this is the review article.
Very interesting. So I would request everyone to join for the next session. That is on 1st of April, 9 p.m.
Thank you, Aarti.
Thank you so much.
Wonderful expert comments. Thank you, Abhishek. Thank you, Mohanty sir.
Sir, presenters may be decided early so that they can prepare